Hello, everyone. This is Paul Sorajja from Minneapolis, and I'd like to welcome you all to this webinar hosted by the Cardiovascular Innovations Foundation. This webinar is on advanced imaging for TAVR, TMVR, and beyond. This is a CME accredited event. The learning objectives are to discuss advanced imaging tools and techniques to prevent, identify, and treat valvular heart disease, explain how the utilization of cardiac CT, AI-guided echo infusion imaging can all help play a role in the advancements of optimal treatment of structural heart disease, identify step-by-step CT acquisition, analysis, and interpretation, describe basic echo measurements and how to interpret images for easy navigation, and also to evaluate the benefits of fusion imaging to navigate. I'm very pleased to be here with key faculty from around the country. I have Dr. Colin, who is the Director of Interventional Cardiology at Vanderbilt, Dr. Robert Burke, who's a cardiologist at the Honor Health Heart Group in Scottsdale, Arizona, and Dr. Joao Cavalcante, who's the Director of Cardiac MRI and Structural CT Cardiac Lab at the Minneapolis Heart Institute. These are the disclosures and off-label use and commercial support. We would like to thank Siemens Medical Solutions for supporting this activity in its entirety. At the conclusion of this event, you can claim CME credit. You can log on at this website, and this website will remain open for the next year to supply you with your evaluation and credit request form. And after this event, please keep in mind we will continue with our webinar series, which has proved to be quite popular. Our next one is Management of Severe Calcification A to Z, and will be hosted on December 10th, 2020 at 8 p.m. Eastern Time. 9 p.m. Eastern Time, 8 p.m. Central Time. And for any additional webinars that have been archived, please visit our website at www.cbinnovations.org. And with that, I'd like to turn it over to my colleague, Dr. Joao Cavalcante, who will be starting off tonight's webinar. Joao, you could go ahead and share your screen.
All right, Paul, thank you so much again for the opportunity to be here tonight. Again, great seeing colleagues across the country, Rob and Colin. And I was asked to talk about the role of CT, in particularly for the evaluation of patients that are going to be considered for potential valve-in-valve TMVR or native TMVR. Thought about talking a little bit about CT acquisition. This is key because if you don't have good image, you're not going to be reliable. And this goes not only for CT, but echo and any other modality. The way we do this acquisition is that we acquire the entirety of the cardiac cycle. So it's a retrospective acquisition. We don't do dose modulation, even though the radiation might be a little bit higher, but we want it to be crisp and clear on our segmentation. We wanted to make sure that we acquire both in systole and diastole. And if we get some enhancement of the right side, that's great. But predominantly, the left side is where we're aiming, obviously, to assess the segmentation and the new LVOT as we talk about. So about cardiac CT, you probably have heard about 64 slides, 256, 320. The higher the number of the detectors, that would increase what we call the Z-axis coverage, which is the coverage from top to bottom. So with one rotation, you will cover more. However, that comes at the expense of a worsening potentially for the temporal resolution because it becomes heavier to rotate. So as important as it is to have greater coverage is actually to have also temporal resolution. And particularly for these patients with mitral valve disease or even for aortic valve, presence of arrhythmias and patients with higher heart rates and heart failure, you have to be quick. Think about temporal resolution as your shutter speed. We want it to freeze motion, and that's what we do. And so if you have a dual source CT, instead of being the gantry rotation time by half, it's going to be divided by 4. So you have a higher temporal resolution with Siemens scanners, and that's what we use in our center. So once you acquire that data set, then obviously you're going to do the segmentation. We use dedicated software by both Tremensio and by also Circle. We wanted to understand the mitral valve anatomy. As you know, the mitral annulus is very fibrotic, different from the tricuspid. There's the anterior leaflet, there's the posterior leaflet with segmentations. And there is this aortic mitral curtain, which is a very fibrotic area that shares between the aortic valve and the mitral valve. So any changes that we do for the aortic valve will have correspondence in the mitral valve and vice versa. We do the segmentation, we deposit these dots, and then for the purposes of simplification, instead of having this anterior horn that goes all the way up into the mitral aortic curtain, we truncate into this trigone to trigone distance, or TT distance, between the left and the right trigone. This is, for simplification, we'll call this the D-shaped annulus. You might be asking, okay, when should we measure? In systole and diastole, this annulus, we measure in both times, and then we do the segmentation. And be mindful that depending on the pathology, there might be some changes throughout the cardiac cycle. Especially in a very dilated FMR, there might not be significant changes, but in some cases we might see annulus that are big in the early diastolic, whereas in primary organic mitral valve, because of the billowing, because of the mitral annular disjunction, this annulus is going to be bigger in systole and ventricular systole. So let's take through a case of a TMVR. Here you have an Intrepid. We do the segmentation, the TT, we measure the mitral aortic angle, and with an STL file, we can simulate the new LVOT. And that's an important concept that was developed by Philip Blanque and others some time ago, showing that when we measure the new LVOT at the very end part of systole, that obviously would be the smallest. However, that's not when most of the blood gets ejected. Actually, most of the blood got ejected in early systole. And so the authors here consider, what if we incorporate all the systolic phases? Then a third of the patients that had been previously screen failed now would be permissible to receive this therapy. So we need to consider the spectrum. This is for Intrepid, but I suspect that this will also be applicable to other valve therapies, which will be quite important. For valve-in-valve, we need to understand, obviously, the surgical report. And if we don't have, then we need to segment that mitral valve and look at the app that Dr. Vinny Bapat has developed, which I will share with you. But trying to understand also with CT, and here's some images corresponding CT and echo and TE, you can see that there is a double mechanism. One here that we have the posterior leaflet that flares. There's a small perforation that creates this eccentric jet, but also a paravalvular leak that will not be addressed with just the valve-in-valve. So both mechanisms are important and shown here. Once we look into the app, then we can see, okay, what is the internal diameter and what valve does the app recommend to be implanted? In this case, it was a BioCore, a 29 millimeters that we confirm, and the app recommends a SAPIEN 3. And we need to know what is the height of this prosthesis and what is the area that gets covered by fabric, because we might need to use that sometimes in patients. So just for speeding it up, we do the segmentation. And one important remark is the differentiation between pericardial leaflets or porcine leaflets. The importance here is that the pericardial leaflets are longer and they will be all the way stretched, all the way to the end of the posts. When you put a valve in, this is going to be a covered cylinder. So pretty much you're not going to use any of that space of the SAPIEN. As opposed to the porcine, the leaflets are short and curled, and then you still have, and by that mean, those could be potentially more favorable if you deal with these patients, so that you have some space to use, even in patients that have borderline LVOT. And that's the importance of the new LVOT calculation, particularly if below 1.7 or 170 square millimeters or 200 square millimeters. That was the most important parameter predictive of obstruction, which is much more common in the presence of the anterior mitral valve leaflet. So valve in ring or valve in Mac, less so in the valve in valve patients, but still important. Just another example, this is now a peri-mount. We can do the segmentation, confirm. We measure the new LVOT, in this case here, 3.23, that's perfect. Patient goes in and the results are favorable, as you can see here. Just another example that I have shown you before, and you can use also the CT to calculate the angle of implant and try to use that. Now, in cases where the situation that you don't have LVOT, so what could we potentially do? So in porcine leaflets, as we talked about, those leaflets are shorter. They don't go all the way to the stent post. So in this case here, if you simulated that the leaflets go all the way to the end, this would be small. But in this case, removing that leaflet that you could measure here, the distance, you could simulate the new LVOT, and this patient underwent a valve-in-valve, and there was no LVOT gradient, and with good leaflet motion and gradients post-implantation. The other possibility would be to try to lacerate, and I'll be glad to have some discussion later with Colin and Paul about the potential for anterior mitral valve leaflet laceration to open it up those free cells so that we can create some space. This is using Tremensio, a small LVOT of 0.3, and when we do the simulation, cutting it open now becomes permissible for this. Or the other alternative would be to try to do preemptive alcohol septal ablation, and you wait a few weeks to have this edema to confirm. Just to finalize, looking at the post-implant CT, things that we want to be mindful of is how the prosthesis sits, how is the leaflet motion. This is obviously our bad cases of embolization, a thrombus and halt in this prosthesis. And these patients typically for a valve in TMVR, native TMVR, they need to be anticoagulated. As you can see here, case of halt. And this is another experience with a transseptal valve that you can look into the post-implant CT and see the procedural ASD and no halt in these patients and good leaflet mobility, but also trying to understand the remodeling that these patients might have after you have implanted. So this is a unique device that we have had a lot of experience thanks to Paul leading our program for the TMVR with the 10-line device. This device has an apical pad that it connects with the tether to the inner valve. And what Dr. Fukui from our lab has shown is that the further away that this apical pad is from the native apex, the worse will be the remodeling of these patients. As you can see that even though you put the apical pad in, on average, these patients had a reverse remodeling, but some other patients had a worse remodeling. And that had to do with the positioning of this apical pad. So in conclusion, CT has a key role in patients for both native TMVR as well as for patients that are undergoing valve-in-valve. You have to have good data set. You have to know how to troubleshoot. Dedicated software is important to assess the suitability. Measurements that you need to be reproducible, and particularly the new LVOT, which is now an evolving learning through different devices and technologies. And I think the post-implant CT will have a key role to help us refine these technologies. And with that, I would like to conclude inviting you all for a course that we'll have in this coming spring of 2021. We did our first and was quite a success. Paul was involved as well as Dr. Bapat. And we would like to invite, and you have more information on this link. And thank you very much again, Paul and everyone.
Well, thank you very much. That was a fantastic whirlwind of CT imaging, especially focused on the mitral space. A couple of questions for you, and I would love to hear from others on their thoughts. Tell us more about the neo-LVOT. I mean, that is really the deal breaker when it comes to mitral technologies, going from with a transcatheter approach, assuming you don't have Lampoon available. The cutoff value of 1.7 is the value that is often the one that people think about. Some studies use, or some trials use 2.5. And as you showed, there's some recent data to suggest that, well, maybe we're oversimplifying this because it's actually a very dynamic measure.
That's true, Paul.
Tell us change in neo-LVOT, diastolic neo-LVOT versus systolic. How do we put it all together instead of using just one number?
Yeah, I think, I would answer by, and one of the continuation of that work is this slide, actually. So when they looked at the implant CTs after, so they decided, okay, we're not going to use just the end systolic, we're going to take the whole systolic and average, even taking a risk. And they look at the post-implant CT, they saw that the correlation of the LVOT, new LVOT, was best, not when they used the end systolic, but when actually they used the multiple systolic average or the early systolic, which is where the blood goes through. And when they look at the CT, actually they could find out that there was quite a bad, overestimation of how this prosthesis would be. So here's the STL file. You can see that the prosthesis would be quite occupying almost the entirety of the new LVOT. But because of the oversizing of the prosthesis, it became not circular anymore, like the STL simulator. It became more elliptical. This AP reduction was actually what allowed the blood to pass through. So I think as the post-implant CT, I mean, I believe that this will have a lot of importance. This is obviously for Intrepid, but that could be also for other devices.
And one other question is how do you take into account the leaflet length and tethering? Because we can predict the knee LVT, I think, very accurately at any phase. But when it comes to the causes for obstruction, it's often related to the leaflet length, which can be difficult to kind of estimate. We often say 2 or 2.5 centimeters makes us a little concerned. How do you factor that in? How do you look at restriction and tethering? And when you're trying to put it together with the neo LVOT, or can you tell me from a CT these aspects?
Well, that's a great question, and it's still very humbling. I mean, whenever we do a valve in ring or a valve in MAC, we kind of, especially when the LVOT can be borderlines. But even in cases, as we recall, that the LVOT was okay, the new LVOT was okay, sometimes the anterior leaflet decides to go towards that and causes the obstruction. I mean, there have been some work showing that if the anterior mitral valve leaflet length is greater than obviously the extent, the height of the prosthesis, you're most likely to be facing a potential for that. 25 millimeters is what they have described as well, greater than that. But it's still unpredictable. And some folks would say that we should preemptively do lampoon for these patients to avoid the bailout. I would like to punt to Colin,
Yes,
as
Colin.
a structural. What do you do? I mean, how do you deal with these patients?
Colin, what do you think?
We've done some lampoon primarily in prior mitral valve repairs where we're going to do a valve and ring or a valve and band. And I find it a pretty imperfect procedure. We think we're going to have this split right down the middle. For us, we come from the septum for both transseptally for both catheters. But clearly you're cutting at an angle. Mm-hmm. And we haven't really studied it prospectively. And then when we go to the OR and do valve in MAC, with a SAPIEN or S3, and they resect the entire anterior leaflet, that seems to be a better approach. So, if we could come up with a way to really obliterate the anterior leaflet, not just put some not random, but imprecise slash through it, I think that may be a better option for these cases. The other two things I wanted to ask you, the septal ablation piece, I'm always a little bit skeptical about, particularly if the septum is relatively normal. If it's a centimeter or less, would you still do that even though the valve is going to obstruct the LVOT? We frequently get told just ablate the septum. Well, it's hard to ablate a normal septum, just to get a valve in there.
Yeah, it's very hard. It's funny because in some views, it's a little ironic that I've had surgeons who are afraid of VSDs bring me the thin hypertrophy septums and say, do an ablation instead, because I'd rather have you do an ablation than me cause a VSD. And the rationale for that is the alcohol can be dripped in extremely slowly with a wave of thrombosis to where it won't extravasate and it's much more controlled. But when the septum is totally normal, 10 millimeters or so, I agree with you. It's very hard to make that judgment, especially when if you're worried about spillage, the Bayesian vein drainage, and what have you. And I think part of the unpredictability, and I think this is an area that needs further study, is that the course of the septals tends to go inferior. And unless you park the balloon just inside the septal, and even consider hanging it in the LAD, the alcohol will tend to go towards the inferior septum, which really will not affect the anterior septum as much because a lot of the obstruction may be in the anterior, which is a problem. So Robert, what do you think? Are you guys doing any of these procedures, lampoon ablation down there?
So we have not had cause to do alcohol septal ablation. I mean, we do them routinely for hypertrophic cardiomyopathy, but in this case, we've not. I work with David Ryzik, and he's been less than interested in creating a problem on top of what we're already dealing with, without any real proof that we're going to provide a benefit. As far as lampoon, we haven't had a situation that we've required it. The one thing that we've discussed and read about, and you guys have probably dealt with this, is Batman actually lacerating the anterior leaflet and then using that as sort of an anchor. That's something that looks intriguing, and intellectually it sounds pretty good, but again, to your point, it's very difficult to make sure that you're going to be completely down the middle of A2 in order to optimize balance without canting the valve, medial or lateral. And then what's your bailout?
Yeah. I mean, your goal is chordal sparing mitral valve replacement, right? And some of the things you guys bring up about the irregularity of where the cuts or placements of these things, even in Batman, can keep it from being truly a chordal sparing procedure, just because of the asymmetry and unpredictability of the cuts.
Yeah.
But yeah, I think it remains to be seen. I think the tools still need to be developed a little bit further. We're still kind of taking a garage approach to the way we do these things with off-the-shelf, off-label therapy. Well, anyway, we'll move on to the next talk. That was a great discussion. So Dr. Burke, we're going to have you speak on echo. So go ahead and share your screen, and the rest of us will go on mute while you're speaking.
All right. So I appreciate you guys inviting me here. So I'm the director of the structural heart imaging team for Honor Health down here in Scottsdale. And disclosures. So the three things that we wanted to talk about were TAVR, mitral valve intervention, specifically edge-to-edge repair, and also left atrial appendage occlusion device therapy. This is stuff that TAVR now seems like old hat to many people. We've been doing it for nearly a decade now, and we've come from making measurements for TAVR placement with a linear measurement on a TEE to now having invariably volumetric imaging as our go-to. And typically it's going to be CT, as you've seen. So what do we need for TAVR imaging? Obviously AS quantification, our annular dimensions, and then we're going to assess post-implant and look for complications. So the quantification, I'm not going to get into this too much. You guys have seen this and understand it. The annular dimensions, really, that's one of the things that echo can also provide us that hasn't been entirely done. This goes back to the very beginning of doing the MVQ with the IE33 to now more automated software that uses AI and to help the echocardiographer to get the same data that you would get on a CT. We use this pretty routinely in our lab. I do it on every case just as a matter of course and sort of practice. And it's been incredibly helpful for making annular measurements and determining valve size in patients that have renal insufficiency, but they're not on dialysis. You really don't want the contrast exposure. And also in patients where it comes as an emergency or an urgent issue. The first case like that was actually a balloon valvuloplasty that went awry, and we weren't really planning on doing an actual TAVR, so we had to make a measurement on the fly. And more recently, a patient who came in with progressive heart failure with AFib RVR and was requiring mechanical support with an Impella. We weren't going to be able to get her down and do a CT without concerns for renal failure, so we made the measurements based on TEE. This is a relatively simple approach. You have a program called Easy Valves with Siemens, and you can go from a volume as you see on the left here, and it will automatically detect the borders of the aorta and the annulus. And it will give this to you in long axis and short axis. You can make some optimization just to make sure that everything is where you want it to be. And what you'll find is that we're typically within a couple of millimeters as far as perimeter, within probably 20 or so millimeters squared with regard to area. Again, on this one, the 3 Mencio that we had from industry did give us a larger area, but I would have disagreed with some of the tracing here with the way that it's done. I also have been tasked with doing our 3 Mencio for our valve program as well. So I think that It's a wonderful tool. It's one that we don't always use, but now that you do have AI to help you out with things like the Easy Valve program, it's really a good option for you. Post-implant assessment for aortic valve, obviously paravalvular regurgitation, looking for mean gradients in EOA and looking for any effusion. Again, this is all getting back into VARC criteria, which everybody has seen. So we won't go into that too much. I was trying to keep this to 5 minutes, and it turns out that we have a little bit more time, so I may babble. Going into the left atrial appendage and the advanced imaging there, initial stuff is still basic. Looking at the left atrial appendage morphology, looking for thrombus, making sure that you're clear to go ahead with the procedure. And then going into left atrial appendage ostium quantification. Now, with what's commercially available with the Watchman, you do linear measurements to determine what really is a 3D structure. So it's a little bit of a step backward compared to where we were with actually going and doing stuff with TAVR. So I generally do stuff also, all of my imaging with a volume on the left atrial appendage so that I can actually look at the ostium, see where the landing zone is going to be with regard to the circumflex artery, and then get a perimeter on that. And we can use that to extrapolate what size device we would want to use and get an idea of what your compression should be. We're also going to look for things like atrial septal anatomy and other complications afterward. So this is a wonderful example of a very large thrombus, which would be the end of your case before you ever started. Right here, you can see in the multiplane extraction here, this goes all the way from the limbus around the left atrial appendage. And here in the y-axis, you see how broad this thrombus is. Obviously, you're going to have a really short case with that one. Left atrial appendage morphology. Again, Mark Reisman has shown us that as much as we would like to provide, a simple descriptor for the appendage, whether it's, windsock, broccoli, cactus, chicken wing, they all have their own fingerprint. So it's not really a one-size-fits-all. Fortunately, though, the os generally will be ovoid to circular and will accommodate the devices that we have. So this goes back to getting biplane imaging. And in my world, I think that when you're dealing with echo, TE, you have to live in a biplane world. Doing all of this stuff as a single planar image is really not helpful. And obviously, for those of us who are used to looking at CT or MRI, everything should be volumetric to the best of our ability. In this example here, you could be fooled into saying, wow, we've got a great landing zone for the Watchman device. We've got the circumflex coming here. We can measure this. We'll know exactly what we've got. Unfortunately, your landing zone would be all the way out to the tip of the limbus. And that's inappropriate, and that's not where we're going to land. You'd end up with a huge shoulder coming over the limbus, huge shoulder here on the mitral valve side, and that's not going to be a stable position for a device. Rather, you have to go into opening up at 0 and at 90 for where the device is really going to land, and then get an idea of how much depth. Now, with iterative changes in the device technology, depth is becoming less and less of an issue. So that's reassuring, and that does help us out, because with echo, we don't always see the full depth of the appendage. And I think more often than not, you're not going to get that information. You really don't see it until you're in there with angiography and seeing what's the full shape of the appendage. But at least this gives us a general idea. Are we going to get in trouble, or do we have to be cautious? So these images now at the 45 and 135, we would get those. And also having the 3D volume. And again, I like to have this because it really gives you an idea of where you're going to be crossing in, what the long axis of the appendage is going to be, and really allows us to optimize measurement of the appendage and really what the landing zone, or annulus, if you would, of the appendage is going to be. So we can go from that 3D volume into a multiplane extraction. You can see the circumflex over here. That gives you your shadow, and you can make your measurements. get a perimeter, which is very useful, or circumference in this case, and then go by your, basically define what size device you want to use. Again, you do have a long axis and a short axis on this, so that's 2 out of the 4 measurements that you would typically want to see with the Watchman device. So when we did that, we went ahead, we were able to put in a 27 device. We had compression, which was great. Again, you do have to go through all of this stuff once again with standard 2D and biplane imaging, just to make sure that you got compression on your device. And that was our final result, which looks good. A little bit of a shoulder there, but nothing terrible. So atrial septal anatomy, I wanted to make a comment on this. The one thing that people worry about when they're doing a transseptal is whether or not there's a previous device in the way. As far as most of what we're doing with the structural heart program, we're very rarely trying to go through a PFO or in an anatomic position that approximates a PFO in order to guide our devices and our delivery system. Almost invariably, we're going to be more posterior and typically going to be a little bit more inferior. So PFO closure devices haven't really posed much of a challenge as far as being a prohibition to doing transseptal stick. And I'd like you guys' opinion on that as far as your own experience, but routinely we've been able to navigate that and not have to make a lot of accommodations. So this is where we come through. You can see that we're posterior and inferior, and this was for a Watchman device. Complications, you're always looking for pericardial effusion afterward. We'll get to that. So for the more exciting stuff that we really have to do a lot of echo, and this is definitely the most effort consuming, it's TMVR and edge-to-edge repair for the mitral valve right now in particular. You still need to be able to quantify the MR with echo. You need to know the anatomy. You have to know the left ventricular anatomy because that's going to impact what's actually happening and why the valve is dysfunctional. Atrial septal anatomy is going to play a role, and then also looking for complications afterward. So this is a case that we did just a week ago. Again, to my point of living in a biplane world, you need to do this in order to determine where is the actual pathology, because you need to know what, really in this case, how much posterior leaflet do you have to work with and where is it in regard to the pathology. That's going to guide the choice of clip selection. Do you want a large clip or a small clip? Do you have enough posterior leaflet to support that? And making sure that you have that specifically at the area of pathology is the most important thing. Again, this does require reasonable temporal resolution, which we do get with echo. Going into a 3D volume here, again, you can see exactly what's going on. In this view, we're going into the surgeon's view, or en face. You have the aortic valve up here, anterior leaflet, posterior leaflet, and then our pathology is going relatively central. Now with this, you see that the actual jet is relatively broad across A2, P2. It's very unusual to get a solitary circular MR jet, and even though we use PISA for quantification, and the assumption is that you've got a perfect circle, in the real world, you almost never do. So we do have AI to help out making some of these measurements. And again, this is the Easy Valve program to look and actually model the mitral valve and help out making decisions, at least as a screening tool for, do we have a large enough valve? Do we have a large enough posterior leaflet? What's going on here? And in this case, you can go into systole and diastole, or specifically diastole and systole, and look for things like, what is the actual orifice area? How much posterior leaflet do you have? And this animation, this program, really takes less than a minute to run. It's maybe 30 seconds or so on a good quality volume set, and will at least get you into the ballpark of, do we have enough orifice area that we're not likely to get into trouble with developing mitral stenosis? And we're typically looking for over 4 centimeters squared. And then, do we have enough posterior leaflet? And for a small clip, you typically need at least 6 millimeters. For a large clip, at least 9 millimeters to be inserted into the clip, and know that you're not going to be at high risk for SLDA as a result of your intervention. So then the guiding of the procedure is really where the echocardiographer has to earn their keep, and making sure that we know exactly where we are with regard to the valve, both medial and lateral, as well as anterior posterior, and making sure that we're going to be focusing on the pathology itself. In this example, you can see how we're centered over the mitral regurgitation. I still have the Nyquist limit baseline shifted here because we're doing that for PISA estimation of the severity of the mitral regurgitation. On this image, we don't have color, and this is actually a Gen 4 device where you can see making sure which control was for the anterior leaflet and which for the posterior leaflet. Again, going into 3D is definitely helpful as far as orienting the clip. And also, in many cases, as soon as you advance the clip into the left ventricle, you're going to have some rotation. There's almost invariably some degree of stored tension, and you have the potential for some bias depending upon how much M you might have on the system. You may dive a little bit more. You need to be very attentive to that, and 3D is very helpful because you can always steer directly onto the device, and then you're not chasing things in 2D up and down and left and right and going all over the place. So in this case, it looks like we're oriented reasonably well as far as a 12-6 orientation. We went down into the ventricle. Now, once we're doing everything for the actual guidance, I get out of 3D. The frame rates are much better, and our detail is significantly better with going into dedicated 2D imaging. But again, I do like biplane. I like to maintain that because we know exactly where we are. And if there are any surprises, you're staying on top of it. So in this case, you can see the arms come down, they dance with the leaflets. Initial grasp looked good. Now, the reason why I show this is that there was no difference in this grasp. If you're not careful, you can fool yourself and not find significant mitral regurgitation. So you have to give your echocardiographer a little bit of time to sweep around, look, define whether or not there's any significant mitral regurgitation. Turned out that this lateral jet was more than we wanted to leave. So made some fine adjustments, moved a little bit more laterally. As you can see here, we're looking pretty good as far as the leaflets tapping, posterior and anterior leaflet. Went, dropped the grippers, and that definitely looked better. So we went into a 3D, and you can see that we've got a great tissue bridge across here. Again, you see the same information here on the multiplane extraction, and then the residual mitral regurgitation was really relatively trivial. At the end, our gradient was 2.6 to 4. This patient is in atrial fibrillation, so average in the 3s, so definitely nothing to worry about. The pulmonary vein flow, which I didn't show you at first, definitely helped to normalize. You see that there's positive flow in systole. This was the left superior pulmonary vein, which was our worst one out of the bunch. So definitely a reasonable result there from that one clip, using, again, large clip in this case. Complications. The one complication that everybody worries about in any of these transseptal cases, whether it's going to be for the mitral valve or for left atrial appendage, is going to be a pericardial effusion. Now, the thing about complications is that they happen when you least expect it, and you need to be consistently vigilant. This is a case that we did basically 3.5 years ago now. That was actually a live case for SIF, and Paul, you might have actually been watching this or there in the audience with us, but went in, everything looks great, no big surprises. They get the wire up into the superior vena cava. You see how that advanced beautifully, no issues there. A little bit of an unusual anatomy, though, on the right atrial side. You can see that we've got all of these cords coming across, really like a fan-like network going across from the crista. Okay, anatomic variant, whatever. So went around, initially had the catheter go across a PFO inadvertently, went up again, and happened to notice, hey, did I miss this to begin with, this little effusion. As it turns out, I didn't. And we never actually even crossed into the left atrium because she started to get into trouble with some hypotension. Within the course of about 10 minutes, we go from this relatively trivial looking effusion to a large effusion here. And this is in the transgastric view. You can see that we're starting to clot up, lots of blood here. So our planned MitraClip case turned into a how to do it pericardiocentesis in very short order. So you can see here, we're going about 5 minutes later. We've got more compromise as far as compression of the ventricle. Just another minute later, you start to see that everything is congealing. This is our pigtail catheter that was up. Start to remove the fluid. You can see that we had improvement here. And within about another 10 minutes, largely resolved the pericardial effusion. What I would say about pericardial effusions is that you just need to be ever vigilant. And for the echocardiographers out there, the best place to look is always going to be transgastric, because you can see everything, and invariably the low pressure side on the right atrium and right ventricle is going to tend to hold on to more fluid. It's going to track there. You know, there are exceptions if somebody has had prior open heart, they have scarring on the pericardium. You know, there's certainly exceptions that you can find, but as a general rule, you're going to find that you can get the best information the quickest by going back down into a transgastric and taking a look there and trying to figure out what's going on. Invariably, whenever this happens, you know, my comment is, guys, I think we have an issue, which translates a lot like Houston, we have a problem, at least in our cath lab. So that's a really brief whirlwind tour of echocardiography for those people that are doing it with live cases and doing it to support interventional procedures.
Thanks very much. Nothing like having to manage difficult issues in a live case. It's always a bit of humble pie, isn't it? And I'm sure, you know, one of the things that CVI loves showing are what I call REEs, or rich emotional experiences. And I'm sure that was a very rich emotional experience to be there live doing that.
Yeah, to say the least.
We'll move on from there in the interest of time. I think we've heard about CT, we've heard about echo, and to bring it all home now, we'll have Colin Barker, who's going to talk to us about fusion imaging. Colin?
All right. Hopefully sharing my screen. Can you see that? Good. Well, I'm going to start with a case that didn't incorporate fusion imaging, but incorporates all of what we've talked about, and then finish up with some of the stuff we've been doing in fusion for specifically tricuspid interventions. So this was a older guy who was very functional until recently, and was diagnosed with aortic insufficiency and mitral insufficiency, as well as a dilated ascending. So in March of this year, underwent an aortic valve repair, which is not done a lot, where they resuspend the commissures and sometimes put a ring in, like a Rankin ring, a mitral valve replacement, and the ascending aorta was replaced, and really never flew, you know, and basically actually continued to decompensate after he had this surgery. And he, you know, we were starting with a very robust, pretty functional guy who now is on oxygen, you know, very limited, and found to have recurrent aortic insufficiency, severe TR, his EF is dropped, and his LV is dilated. So one of the issues that came up, and we can kind of interact during this case if you want, but is, what did he have an ischemic event? He didn't have any coronary disease, and did something happen during his procedure, since he had this drop in his EF and this decompensation? And we hadn't gotten his coronaries done again, but we had to get another CT for sizing. And one thing we're doing more and more of in our pre-procedural planning, in fact, we are doing it entirely exclusively now, is if we can get good quality CT images where a CT angio is reliable, or if there's question, even in these cases of a pretty sick guy, we'll send it off for a physiologic assessment. So this is our patients on the right. On the left is an example of someone who just came in recently for a TAVR evaluation, sent his CT off for CT FFR and discovered that he has pretty significant LAD disease as well as RCA disease. So I don't know, but before I go on, and so this was posed to me the other day by a surgeon. Would you send someone, a young person with aortic valve disease and the CT on the left for a CAB AVR, or would you still want a cath?
I think Patrick Sorois is having this trial ongoing right now, if I'm not mistaken. So he is randomizing. I'm not sure if it inquires if it has FFR assessment, but he is posing that exact question. He's calculating the CT-based syntax score and trying to use that as, and you don't get the cath. So, yeah, in this case here, it's a bit challenging, Colin. We have not been doing a lot of, we do have CT-FFR for us, but it requires pre-TAVR. For any CT-FFR assessment, requires nitroglycerin, so coronary vasodilation to simulate hyperemia. And typically to get decent images, you need heart rate control. So in TAVR, we typically don't give beta blockers, although we could. And we certainly don't give nitroglycerin. So the accuracy is a little bit in question, but, for this case particularly, I'm not sure, maybe the distal RCA has something there that is below 0.8. The FFR and the LAD seems to be a little bit on the borderline 0.8 or so. There's a septal that is red, but it's an interesting question.
Well, when you say, I mean, I'm looking at this and I'm thinking, there's no severe proximal disease, right?
Yeah.
Right.
And I think that's kind of the debate here, right? Do we chase stable distal ischemic disease? And that's, if I saw left main or proximal disease, I would say you probably should do an angio, but distal or diffuse distal disease, it's a little suspect. I don't know where you're going with this, Colin, but
no, nowhere. It's actually, do you believe this? That's sort of where we are sort of stuck right now. Is this enough? And we don't know. I mean, we still end up cathing these people a lot, maybe, but at the time of the procedure.
Yeah.
So here
go ahead. Patient, right? I mean, if this were a diabetic, previous MI, known coronary disease of some sort, I might have a different threshold from somebody who has never had angina and is different. I don't know. It's a little hard to say exactly.
Mm-hmm.
Yeah, sorry to interrupt.
No, that was the point. I was hoping this would be interactive, and I think that's our current sort of debate frequently, is what to do with these CT-FFRs. I do believe I don't know if I'm biased or not, but I really do believe that that is going to be the future of evaluating people for ischemic heart disease. So here's his echo when he gets sent to us, and you can see the bioprosthetic mitral valve, the EF clearly down. Hard to quantify, but some degree of aortic insufficiency. We get a TEE, and here he clearly has a fair amount of aortic insufficiency. And again, remember, this was a repair with basically some pledgets that were resuspending, some pledgeted sutures to resuspend the commissures. So again, somewhat interactive here for Robert and Joao. When it comes to measuring calcific aortic stenosis, we know what to do. But what about when there's no calcium and it's aortic insufficiency? How do we size? How do we pick a valve? And that's sort of the challenges we had here. Obviously, just like you guys, we have access to all kinds of different devices and valves. If this was aortic stenosis, it's a pretty easy decision. But with aortic insufficiency, with essentially no calcium, it became a little bit of a challenge. And not to belabor it, but have you guys have any insight into measuring for aortic insufficiency with no calcification? And we're obviously going beyond what we're doing in routine practice now.
Joao, you want to comment on that?
Yeah, we had done a couple of cases when I was back in Pittsburgh, actually LVADs with significant AI. Those are tougher because you have the sucking from the cannula. But I think you have to oversize, and your area there and your perimeter will be right in the range that you could do, nicely. Now the choice was whether you're going to go with a Sapien or you're going to go to an Evolute. But the absence of calcium, although we are more fearful, for holding purposes. If you oversize, you have a nice sinus of Valsalva diameter there, you'll be okay.
Yeah. Well, and also the area here, 363, you're going to be quite a bit oversized with a 23S3.
Yeah.
So that amount of oversizing actually could work quite well. The perimeter oversizing, that kind of depends on which valve you choose. That could be a little bit less oversized for an Evolute here at a perimeter of about 69.
So we made a little bit of a historic choice here, one that we couldn't do today.
Oh.
And the reason we went this way is that we
25.
could completely deploy the device and test it, as far as risk of embolization. And if we liked it, release it, without much risk, with what we feel would have been a fair amount of good radial force. So this is, may they rest in peace, the Lotus valve. And we gave it a decent tug test here, and on echo and fluoro didn't really appreciate any movement. This is a 27 millimeter Lotus. And then when it came to the literally the last sheathing aid coming off, the whole room deflated. Because we had been getting so much slack. Like, you're really going to TAVR this guy? I was like, yeah, we got a great plan. We got it all worked out. It's going to be fine. We're going to put the valve in. We don't even have to release it. If it sits right, we're good. We're going to let it go. And it let go. So there it is, flinging around in the ascending. And luckily we maintained wire. We didn't anticipate this, but we had a core valve on backup, an Evolute, in case we did get into trouble. And so we ended up putting in a 29, sorry, I jumped ahead, a 29 Evolute. And it actually came out pretty nicely, but obviously a Lotus in the descending as sort of a bonus valve. And he did okay. I mean, this guy took a beating from his original surgery, but did eventually get discharged from here. We didn't see him in 30 days follow up, but got a call. He lives in Kentucky, and got a call from his cardiologist, and he's doing better. He's definitely not who he was before the initial operation, but he's clearly recovered, and we learned a lot here, and I think learned a lot about what we don't know about sizing for aortic insufficiency and when there's no calcium, etc. You're probably right. With a 26 S3, we may have been just fine. But we liked the historical idea of deploying this valve entirely.
Well, I think it's, Colin, I think it's a great choice. I think a lot of people would have done that.
Yeah.
Just out of historic curiosity, was it easy to lock the valve?
Very.
Yeah. There you have it.
The easiest one we had.
Yeah, there you have it.
And it looked a little barrel shaped, so
Yeah, it was exactly. If it was an AS case, we probably wouldn't have taken it.
Yeah, because it's too easy to lock.
Yeah.
Yeah, there you have
so
it.
That's just in closing, just to get to some fusion, I just wanted to show this one case and Paul kind of get or all you guys' perspective on this. And this is for jumping all the way over or all the way back to the tricuspid valve. And we've done this a couple of times. This was when I was in Houston, you know, with Mike and Steve and Neil. Some CT fluorofusion for us, Paul, to sort of orient on a fluoroscopic level where the anterior septal and posterior leaflet is, not only in circumferential, but in sort of superior, posterior, anterior, lateral. And I found this to, if you can look at the lower right image here, this was very helpful on fluoro to know where the anterior and septal leaflets were and to orient, you know, the graspers. So I think, you know, I'm trying to do more of this. As you can imagine, it takes a little bit of an effort on a lot of people's part to get this done, let alone starting with the CT, get right-sided CT images with contrast in the right-sided chambers, and then having a patient where you have something to fuse and co-register. But, you know, these tricuspid clasp and clip cases are such a pain that if we can get anything to sort of facilitate orientation and success, I think it's important. So we're going to continue to try to push this and get better at fusion imaging, but I think it'll make these procedures more successful and more efficient.
Well, thank you, Colin. I actually love that we end on this slide. This is, I mean, just beautiful. You know, I was almost late to this webinar because I was actually with a tricuspid valve replacement company in their lab. And I actually had told them that we needed overlay a CT to do this procedure properly. And so I actually think for right-sided tricuspid imaging, because echo can be quite challenging, that CT overlay, especially for replacement technologies, has a very bright future. The clip, we have done overlay like this, especially when we were earlier on, and I wanted some ideas how to steer things well. And you can get a beautiful projection that matches the fluoro image where you divide the top and bottom halves of the valve into the anterior and posterior segments. And it works very well. Joao has done it for me. And I know we're looking at it in the TRILLUMINATE imaging sub-study. Joao, you want to comment on that sub-study and kind of what's going on there?
Yeah, thanks, Paul. It's a study now that we are enrolling. We have a target of 100 patients that are being evaluated with the TriClip. So 2/3 would receive a clip, 1/3 is going to be randomized to medical therapy. We're looking at baseline CT and MRI and trying to understand exactly how does the ventricle do in terms of the response after you have relieved the the tricuspid regurgitation. And it becomes quite challenging to image this group of patients, as you said, Colin. Correct protocol for the right side enhancement, dealing with arrhythmias, dealing with fast heart rates. And, I'm biased obviously by Siemens, but I tend to believe that there's no better product out there, having seen scans from other sites that can deliver consistently good quality images. So it's going to be good to see, what exactly happens at 1 month and then at 1 year after you have relieved the tricuspid regurgitation.
Yeah. Robert, I want to go back to your presentation because I had one question for you. You showed sizing of the aortic valve by echo.
Yeah.
And we did that in a few cases, especially those who cannot have contrast because of kidney issues. And we actually did sizing by echo and then did IVUS of the periphery. So then you never require contrast for the periphery or the heart. Do you see that as a role? I mean, tell me, how often are you using the sizing by echo for aortic valves in your practice?
So as a matter of an upfront strategy, a couple of times a year, we just don't have that many people that are on that cusp where you're worried you're going to put them into renal failure, they're going to be on dialysis, and they are steadfast. I won't do this if you get rid of my kidneys, so when they put a gun to your head, that's what you're going to do. But I think that from an echocardiographer's standpoint, you need to make it a discipline to routinely get that data so that you're facile with it, because it's really hard to pull something out that you don't do with any regularity and then expect the results to be consistent, predictable, and reliable enough that you're going to go and basically stake, this person's life on your outcome. Bad things happen when you don't have the right size valve. We know that. Going back to the original days of Sapien, we had valves embolize just like you showed with the AI case, but they were stenosis. And our 2D measurement, a linear measurement for an LV outflow tract diameter, was just plain old wrong. We just didn't have the right data. So you want to use the volumetric data. You want to be facile with that and just be able to use that to help out.
So I guess it's a CT world after all.
It's a volumetric world.
Any other comments, Joao, Colin, Robert, any other comments? Yeah, Joao?
Yeah, I was going to ask Rob, in regards to, it was nice to see that segmentation of the mitral annulus. How much manual input do you need to give? You acquire a volumetric data set, and how you segment, do you need to do any input? And how do you deal with patients with arrhythmia? So
it's all done actually with live imaging. So there is no reconstruction as far as any of the Siemens data sets. You don't have multi-beat acquisition like some of the other companies. So what you get is based off of one beat. The biggest issue goes into optimizing the image, getting the right compression, going into temporal versus spatial resolution, trying to get that. I find that I do a fair amount of micromanaging on that. I'm a little bit compulsive, maybe just a little. And I like to make sure that I know exactly what I'm dealing with. And again, like you had brought up, trigone to trigone distance, you have to make sure that you've got that right. And almost invariably, that one you're going to adjust. And I'm sure, you've done it as well with CT. You have to look at this and sort of go back and forth, one frame back, one frame forward. What does it really look like? Okay, now I'm happy, and be able to make your measurements. But from a screening standpoint, as far as, is the valve large enough? Do you have some posterior leaflet? It's a great, really quick tool. The AI is wonderful for that. But when it comes to making very specific measurements, yeah, I'll micromanage all of that stuff.
Fantastic. Well, it's been a great webinar, and I want to thank the outstanding faculty and key opinion leaders in this space. Also want to thank Siemens for supporting this. Again, we had record attendance today, and many more signed up online, and welcome you all to provide your feedback, and looking forward to seeing you all again in the very near future, hopefully with the current crises abated very soon. I miss you all, and I wish you all the very best of luck. Bye-bye now.